We are coming now to the next talent. It is my honor to introduce Jakub Krzyzkowiak. He's an upcoming gastroenterologist from the famous Marie Sklodowska-Curie National Research Institute in Warsaw, and he's coming from the famous group which published a lot of articles on colonoscopy from Michael Kaminski's group, and he will talk about short and long-term outcomes of endoscopic removal of large colorectal polyps by morphology. Please, Jakub.
Hello everyone, thank you for the nomination, and it's a great pleasure for me to present today the results of our study on short and long-term outcomes of endoscopic removal of large rectal and colonic polyps. Although polypectomy is one of the most common procedures in gastroenterology, there are still some significant knowledge gaps in the field of large colorectal polyp resection, such as short-term effectiveness by lesion, location, rectum versus colon, in different morphologies, like pedunculated polyps, sessile lesions, and laterally spreading lesions. The second gap, which is significant in clinical practice, is long-term risk of recurrence and risk of colorectal cancer in the future after resection of a large colorectal lesion. So the aim of our study was to address these gaps. And this is what we did. We assessed all the lesions larger than 20 millimeters detected during colonoscopies performed in our center between 2000 and 2015. After exclusion of not attempted resections, IBD patients, and missing data, in the final analysis, we included 1,651 endoscopically resected lesions. And in the follow-up, we assessed technical success, complications, histology, recurrence, and the risk of colorectal cancer in the future after resection of a large colorectal polyp. Just to give you an idea of the analyzed population, here are some baseline results. The median age was 64 years old. There were more men than women in the cohort. 26% of the lesions were located in the rectum, and over 40% of the lesions were more than 30 millimeters in size. And the morphology, around 1/3 of the lesions were pedunculated, 44% were laterally spreading lesions, and 25% only were sessile lesions. We followed up patients in the hospital records and the National Cancer Registry for median follow-up time, which was around 8 years. And this is what we found. The technical success was high, but there was a significant difference between rectum and colon, which was driven mainly by a high rate of success of resection of laterally spreading lesions in the colon. The same trend was seen in another A point, which was bleeding, and again it was driven mainly by high bleeding incidence for rectal laterally spreading lesions, which was over 15% in the rectum versus only 6% in the colon. Then we looked at the advanced histology, the high-grade dysplasia, and the PT1 cancer. There was a significant difference between colon and rectum in both of them, in high-grade dysplasia and PT1 cancer. And again, it was caused mainly by the difference in laterally spreading lesions between colon and rectum. And in the, as far as the PT1 cancer is concerned, the difference between colon and rectum for LSLs was as high as 9.3% in the rectum and only 1.6% in the colon. So a really, really high difference. Then in long-term results, we found that the risk of recurrence was three times higher in the rectum than in colon overall. And again, the highest difference, the most evident difference, was observed for laterally spreading lesions. It was also confirmed in multivariate analysis, as you can see the hazard ratio on the right. And for the long-term colorectal cancer risk in the future after resection of a large colorectal lesion, there was also a difference, the same trend, but in this case the results didn't reach the statistical significance. But the result which drew our attention was that 70% of the lesions of the colorectal cancers were found in the same location as the large polyp resected in the past. So it was, it was 70%, a high percentage of the colorectal cancers. And in conclusion, the risk of technical failure, of bleeding, of high-grade dysplasia and PT1 cancer, and for recurrence was much higher in the rectum than in colon. The same trend was seen in the risk of developing colorectal cancer in the future after resecting a large colorectal polyp, and it was driven mainly by the differences in the laterally spreading lesions. It should lower our threshold for en bloc resection, especially in the rectum. Thank you very much.
Thank you very much, Jakub, for this very interesting presentation, these data. How can we put this now into the clinical practice? I think the problem is sometimes that when we have larger polyps, often when you see only the pictures, there's an underestimation, and then patient comes and you are prepared for an EMR, but not for an ESD. How you deal in Warsaw with this problem? Do you scope every patient up front again before you do the resection, or how is your strategy?
Well, yes, we try to check it by ourselves, but if it's possible, every time we try to switch, and if we consider that en bloc resection is the right method, then we try to do that.
So finally, in every of such procedures, you are prepared for EMR and ESD as well?
Well, we try to be, right. So we try to be ready for everything. So if it's possible, we try to switch.
Thank you very much.
Thank you.